Well, hello and welcome. As Lynn said, I am Jory Berry. I am president and CEO of the Immune Deficiency Foundation. And I really just I want to thank you for taking the time to be here today, which I know people always say that at the beginning of calls that are like this, but I also know I said this on a recent call that time really is a precious commodity. And I can only imagine what life on the Hill is like right now from all the way here in Texas. So that is a sincere thank you. But your time really is well spent here today because we're going to talk about people whose health status makes them the most vulnerable to threats from infectious diseases. And that's why the Immunocompromised Collaborative was created during the pandemic, really to give these communities a united voice. And Lynn Albizo will share more about that in a minute. You know, in so many ways, the world is moving on from COVID, but the communities represented by the Immunocompromised Collaborative, they really don't have that luxury. And masks and social distancing, that was really embraced and understood by the general population not so very long ago, but yet now in some ways is kind of deemed unnecessary and trivial. But yet that could be life-saving for someone with an immune system that struggles to overcome what some would consider minor infections or viruses, much less significant ones. So we might not be able to change that, and that's not really what we're here today to talk about. But what we can do is address gaps in access to COVID therapeutics and treatments and keep other protections in place, be that access to antivirals, the benefits of telehealth, or funding for public health initiatives to support community outreach related to COVID prevention and treatment. So that's why we're here. Thank you for placing a priority on this issue. And the reason that I know it's a priority for you is because you could have chosen to spend your time elsewhere, but you chose to spend it here. So for that, again, thank you and welcome. So now I'm pleased to introduce a key leader for the Immune Deficiency Foundation. You heard a little bit from her earlier with some of the housekeeping items. Lynn Albizo, who is our Chief Public Policy Officer.
Thank you, Jory. Greetings and thank you for joining us. To give you some background, we at the Immune Deficiency Foundation launched the Immunocompromised Collaborative at the beginning of the pandemic to provide a united voice for the immunocompromised community, including people with blood cancer and autoimmune conditions, primary immunodeficiencies, and organ and bone marrow transplants. Our steering committee includes the Immune Deficiency Foundation, the AIDS Institute, the American Kidney Fund, the Autoimmune Association, the Lymphoma Research Foundation, and the Lupus Foundation of America. We collectively represent nearly 10 million people, or 3% of the population, who have immunocompromising conditions and who remain at risk of the many viruses and pathogens circulating, including COVID, flu, and RSV. The risk of progressing to severe COVID-19, leading to hospitalization, complications, or death, is higher for immunocompromised people. Many people who are immune compromised do not mount an adequate response to vaccines and must be extra careful to avoid infections. Millions of Americans at high risk of developing severe COVID-19 aren't even aware of their susceptibility. Today, you will hear from patient advocates about their experiences and those of the communities they represent. You will also hear about the results of state listening sessions that the collaborative hosted with health policy leaders on the importance of access to antiviral medicines and telehealth access, and the need to support public health systems. We will also hear from the American Telemedicine Association on the telehealth legislation to make permanent telehealth flexibilities that are essential to those who are immune compromised. And with next slide, please. This is, we have the agenda here, you can see, and with that, I'm going to first introduce Karina Escamilla, from the director of the Latino Religious Leadership Program, Latino Commission on AIDS.
Thank you. Thank you
Go
so
ahead.
much. Yes, perfect. So yes, I'm Karina Escamilla. I'm the Deputy Director of the Latino Religious Leadership Program that is part of the Latino Commission on AIDS. Next slide, please. Okay, the Latino Commission on AIDS is a not-profit organization founded in the 1990 in response to the critical unmet need for HIV prevention and care for Latinos. The Commission realized their mission by spearheading health advocacy for Latinos, promoting HIV education, developing model prevention programs for high-risk communities, and building capacity in community organization. This is through a big, extensive network of organizations. And we serve mainly the Latinx LGBTQ population, and we are very committed to promote a safe space for the LGBTQ community. And with the commission, we found the Hispanic Health Network that is dedicated to eradicate the health disparities in our communities. Next slide. With all this experience in the HIV and with all our programs, over these 4 years, now we are 4 years of the COVID, the Latino Commission were in the front lines. We witnessed the impact of COVID in our community. At the beginning, it's very painful and that our clients living with HIV and their families were among the most vulnerable. And this was because most of them have to stay outside of the safe of their homes, and they expose themselves to a very high risk because of the work and the reality. And the mortality rate among the people living with HIV, we are going to see, began to climb. And also another part was the fear and the misinformation that were around the communities. I think everybody recalls 2020 and with all that notice, and there were a lot of fear and a lot of myths. Also, in response of that, we start campaigns. We collaborate to do and launching campaigns to disseminate accurate information. We are making these campaigns tailored to our population. Most of the campaigns were in Spanish. We collaborate with Proceed and with CDC, and to inform our population that was very, very, very scared and with a lot of misinformation. And because we know that knowledge was power, and empowering our community with the right information will save a lot of lives. So we start these campaigns, but as soon as the vaccines became available, we waste no time. We team with the New York State, and we're in New York City. My office is in New York City. Also, Latino Commission on AIDS work nationwide, but in New York City, we work with the New York City Department of Health and the network of the faith organizations that are part of my program, the religious program. And we start the vaccination campaigns just to the community, to protect the community in their space, because we know our community with all the experience that we have to go where they are. And we found that another thing that was very, very, very deep, that there was a lot of health inequities, because we realized that most of the people that came to the vaccines, lack of an insurance, they don't have a primary doctors, they don't have where to go to have the services. So we know that this access to health is still a luxury for few. So we are trying to bring all the services to the community. And we need these services like perceived over the time, because COVID is still with us. And then another program that we make was the COVID response program that you will see in the logo. This program was a program that we create to train community health workers and let them go to the areas with lower vaccination rates and high COVID incidence to promote the vaccination, to give them health education, to give them PPE materials, so be in the field, because we know that was part of our mission, to go to the field. And if you go to the next slide, please. So that was our in-person activities, but also we make virtual activities. Thank you for the technology. And as an ally, we transfer some of our activities on in-person activities to the virtual. And we deliver webinars with doctors and experts who meet our clients despite this isolation, be informed, safe, and care. For example, you can see here the Saludes Vida. We have a group of people living, old people living with HIV. They were very, very alone. So we bring experts to talk about this theme. And also we have contact with doctors that explain in Spanish in a very good manner how to handle the pandemic in the more safe, informed way to all our clients. Also, some of our services, we have it essential because we cannot want to put in risk our clients going to our office. So we also made that change. That's why telehealth is something that we support. And then we have to redouble our efforts because we cannot leave these people that are very vulnerable. And we know that health is a fundamental right, and everybody deserves like have all this. And this all the programs that are community-based, we are like supporting and doing that. So let's work together. We learn a lot with this experience. The mainly thing is that working together, collaborations, be part of collectives, be part of everything was very important. And yes, there's a lot of things to do, and we need resources to do that. So thank you, Lynn. Thank you for making us part of this reality and this effort. So that's thank you.
Thank you. Thank you so much, Karina. That was really wonderful hearing about all the work that you're doing. And now I'd like to introduce Sarah Flanagan. She's a patient advocate from the state of Maine. She'll be speaking about the issue of access to telehealth for specialty services, including immunology, pulmonology, and dermatology, and the use of COVID antivirals for the immunocompromised community. And welcome, Sarah.
Thank you, Lynn. As Lynn said, my name is Sarah Flanagan, excuse me, and I have common variable immune deficiency, and I'll tell you more about that in just a second. But this was actually diagnosed following very frequent infections as a small child and then contracting mumps when I was about 4 years old, despite being vaccinated. So it really triggered my providers as a young child to kind of figure out what the puzzle was to get the mumps when I was around people who are vaccinated. However, this was pre-online charts and Googles, and my parents weren't really aware of the exact diagnosis, other than that I should always take my vitamins and be immediately seen for any infections. My mom always mailed me vitamins in college because she thought that would fix the problem. Excuse me. So CVID, or common variable immune deficiency, is one of about 450 primary immune deficiencies. And these are rare chronic conditions where part of your immune system isn't functioning correctly. And specifically for CVID, it is the most frequently diagnosed and tends to lead to an increased number of infections, susceptibility to infections, and also the length of the infection. There's also a lack of specific antibodies from vaccines. So I don't respond to vaccines. I receive all vaccines, but my body doesn't develop a response or a protection, if you want to think about it like that, to someone who doesn't have a primary immune deficiency. So essentially for me, even though I get vaccinated for anything recommended by my providers, it doesn't mean immunity. I don't build antibodies like others. And so I need other protections and I need access to medications. And to tell you a little bit more about my story before I go into access to services, I lived in Kentucky until about 2012, and I ended up moving from Kentucky to my current job at the University of Maine because of significant lung and allergy issues in Kentucky. And there I was re-diagnosed as an adult because of those issues. And I was very fortunate to have a very knowledgeable immunologist who was able to not only identify CVID, but also prescribe IgG or immune globulin. This is a medication that is created through plasma, and it essentially gives me antibodies to protect against infection that I don't make myself. I will apologize. I very ironically caught COVID. So I can definitely give you firsthand experience right now. One thing I want to emphasize throughout my journey has been the role of insurance and having knowledgeable doctors. It's always very stressful when my infusion has to be reauthorized through insurance, even though it's been, gosh, 15-ish years now, to make sure that I have the needed labs and the coverage of IgG and the associated medical care like telehealth. So one thing I always like to make sure I point out when I'm asked to describe my immune system is that CVID is not just one issue. I do want to acknowledge that I am incredibly privileged to have a really good insurance policy through my work. And I also have an incredibly flexible schedule as a faculty member at a university. So I was able to be very, very isolated for basically the first 2.5 years of the pandemic. And the impacts of CVID and other immune deficiencies really differ for everyone, and they really require a lot of different types of providers. For me specifically, I am very talented at strange things. I have a moderate hearing loss now because I had chickenpox in my ears as a small child with lots of ear infections, sinus infections, various skin infections. And my most challenging issue really stems from my allergies and my severe asthma. But I love being in Maine because I can go outside without breaking onto hives. However, all of these things really signal why it's so important for me to have healthcare providers. As you all may know, Maine is an incredibly rural state. I live in probably one of 4 to 5 more populated areas. I live in Bangor specifically, and there's a healthcare shortage, much like other places. For me specifically, if I don't have access to a provider in my area, I may have to drive 2 to 3 hours on the interstate to access other providers, may even have to leave the state. And just, I'm a worrier and I always worry about the weather in Maine. And so it's not practical to always be able to leave the state or to travel to, say, Portland or Boston to be able to access routine care, especially if it's something that's needed immediately. One of my big challenges is my CVID is not actually currently treated by an immunologist. It's treated by an allergist who has training in immunology, but he is not an immunologist. I had one, but that individual left a week into the pandemic. So that was very stressful for me. And also what has created another challenge and really necessitated telehealth is my pulmonology office closed about a year ago. And just because of larger system issues, they have not opened and reopened through the local hospital. And they're one of the only pulmonology offices in this area. If I wanted to access a pulmonologist who has experience in my specific lung-related CVID issues along with asthma, I would have to leave the state. And I know it is a very long wait. The same way too, dermatologists, I get a lot of skin infections, are also few and far between in this area with very long waits. So I've accessed telehealth for that through my insurance. Because of that, I want to speak to the importance of telehealth for me specifically, but I know it also applies to others. Because of my rural area, I am able to access specialists that are not in Maine, or maybe that I wouldn't even be able to see. It also lessens the burden of travel across state lines and long distances. Because, at least for me specifically, things tend to pop up very quickly, and it may not be practical or even possible to drive, multiple hours on the interstate to see someone for 30 minutes when I could see them via telehealth. It also, I'm very fortunate with my insurance policy, but there's also the costs with having to travel. And while I'm able to travel to some degree now, others who have more significant needs or co-occurring disabilities or families or whatever it is, there's a number of barriers to physically accessing healthcare. I actually continue to access telehealth now because my doctors see that the increased rates of COVID right now really put me at increased risk of exposure to germs. So when it's possible, they've allowed me to continue accessing my providers via telehealth, especially when a provider doesn't actually need to physically see me and I can kind of describe what's going on. One thing that's really important to me, I work a lot with schools, and it's really important to me to have a regular work schedule that is flexible, that I don't have to take a day off work. I can do my appointment from my home, from my office. But I also think about my background's in special education, and I think about telehealth as equity. Public healthcare and telehealth, it needs to give equity and access to patients with various risk factors like me and others who have challenges to accessing healthcare. Because for me specifically, access has allowed me to really maintain my health and my quality of life as much as possible, and also potentially access providers outside of my beautiful state of Maine, but very rural state of Maine. I am very fortunate right now that my insurance is continuing to cover telehealth, but I know that will not always be the case. And one thing I want to talk about is because of my access to healthcare and medications, I've been able to travel and engage with others in person for the last year. And it's something I'm incredibly grateful for. I'm a very social person. And I was excited to rejoin humanity after being so isolated. But I was speaking at a conference recently and contracted COVID. And this is a very scary experience to me because of the lung damage I have. And I'm extraordinarily grateful to my primary care office. My specific primary care provider and allergists weren't available when I tested positive. They were both on vacation. But other providers were able to view my file and prescribe needed antivirals. Then I very much appreciated that my exact providers were able to answer questions via our online platform. And just knowing how severe COVID could have been, I'm just so incredibly grateful to how quickly they responded through giving me immediate antiviral treatments. One thing that was really important is that I had choices between what I could take. And the nurse practitioner really did some research and talked with other providers about which ones would be the most appropriate for my needs and for the other disorders and medications that I take. So very, very grateful. One other thing I want to add is that I have been very privileged to receive additional boosters for COVID to allow me to continue engaging in society, and also the pre-exposure prophylactics for prevention when it was available. And I know these are not available now, but these are incredibly valuable to me and to others to prevent illness or to potentially lessen the impacts of it. And so I just want to thank all of you for listening to me today. And I'm happy to follow up with anything, but thank you for listening to my experiences.
Thank you, Sarah. That was wonderful. And I think you really gave a good picture of what it's like for people who are immunocompromised, and really appreciate that. As was mentioned earlier, and as Karina participated in January, the Immunocompromised Collaborative hosted state listening sessions. They were focused, they were virtual, but they were focused on New York and Texas. And they bring together state, city, and county officials, medical professionals, and patient groups to discuss how to protect the nearly 10 million people in the US who are immune compromised. The goals of the listening session were to hear from health policy leaders and community members and to identify access gaps, understand patient and provider hesitancy, risk status awareness, to discuss policy solutions moving forward to improve access to COVID-19 treatments and to highlight state barriers to vaccine access. And you can see the different objectives up on the screen. There are treatment options available that can help reduce the severity of symptoms and the risk of hospitalization and death among people who are at high risk of severe COVID-19. Unfortunately, many of those who need COVID-19 treatments called antivirals do not know treatment options are available and are not getting them. The listening session was an opportunity for the collaborative to hear from a diverse set of thought leaders and to help frame our policy work going into 2024. And at this time, it's my pleasure to introduce our two state moderators who led the discussion with a series of questions. And we have Nick Armstrong and from Manager Advocacy and Government Affairs from the AIDS Institute, and Deborah Darcy, Director of Government Relations at the American Kidney Fund. And we'll start with Nick.
Hi, folks. My name is Nick Armstrong. As Lynn said, I'm the Manager of Advocacy and Government Affairs at the AIDS Institute. We are a national nonprofit focusing on increasing access to healthcare for people living with and at risk of HIV, hepatitis, and other chronic conditions. And we're also one of the steering committee members of the Immunocompromised Collaborative. I had the pleasure of moderating the listening session for participants from the state of New York. We had a pretty diverse group of stakeholders who participated, including people who represented medical societies, county and city health departments, pharmacists, patient groups, PBMs, as well as academics. And we also had Karina from the Latino Commission on AIDS, who you heard from earlier. And there's a lot of really interesting takeaways from the listening session, but I wanted to highlight a few of them that I thought would be most relevant that we thought would be most relevant for policymakers. To start with, the participants, especially those in the public health field, really emphasized that the public health system is in a lot of financial strain, and they have been, quote unquote, dramatically contracted. So they noted that their budgets are really being slashed. They're being asked to do more with less funding. And with those small budgets, they've really had to focus on targeting outreach to certain populations. So they've been focusing on certain zip codes, high-risk elderly populations. Karina noted that they were focusing on Latino patients who don't have primary care. And because of all these constrained budgets, they haven't been really able to reach all of the populations that they wanted to reach, and really have to think about prioritizing those higher risk groups who have higher risk of COVID complications. And essentially, they said that as pandemic funding is drying up, they still need support so that they can ensure that people who are at risk of COVID receive the public health messaging necessary to keep them safe. And we also asked the participants about some hesitancy on the part of either patients or providers to prescribing antivirals for people who test positive for COVID. The group noted that there was a widespread use of, they noted that widespread use of antivirals has really been constrained by a few different factors. They said a lot of times people's symptoms aren't severe enough that they believe that they need antivirals, even if they are immunocompromised. They also found that as people are testing at home, which a lot of folks do, sometimes they miss the window that that's required for them to get those antivirals, or their doctors have concerns about drug interactions. And finally, they talked a lot about the hoops that people have to jump through to get the medication based on their insurance status, who their insurer is, authorization forms. It requires a lot of work on the provider side, and some providers don't have the capacity to perform that. They also noted that all of these barriers have resulted in some missed opportunities to get people on antivirals, which have led to people being hospitalized for further COVID complications like pneumonia. We also talked a little bit about how pharmacists play a role in ongoing COVID response, specifically test and treat programs that are working within pharmacies. The pharmacists who were on the panel talked a lot about how pharmacies are a great place to do a lot of important COVID response work because there are so many pharmacies across the country. However, retail pharmacists right now are really overwhelmed and don't really have the capacity to do a lot of the necessary work for test and treat for COVID. They said they're being asked to do more things with less staff or less resources, and they still have to focus on the day-to-day operations within their pharmacies. There have been many pharmacies that have been closing across the country. Hours have been shortened, and some retail pharmacies are really facing labor shortages because of this. The participants in the public health departments also noted that they're having a lot of trouble with commercial claims for antivirals. They said they face rejections from insurance companies and have to deal with the burdensome prior authorization to get prescriptions filled. This is especially concerning because it's vital to get people access to these antivirals within a certain window of time in order to prevent those worsening symptoms. And they noted that they have to spend as much as 45 minutes on the phone with insurance companies in order to get just one antiviral authorized. And this can be challenging if you're dealing with a lot of patients who need the antivirals while still providing the services to other patients. And then finally, the listening session talked a lot about the importance as well as challenges of telehealth for populations that our participants served. They said that telehealth is really a lifeline for a lot of immunocompromised patients. I know Karina talked a lot about it in her discussion earlier. And telehealth really allows care to get to people without having to leave their homes. However, there are still some challenges because some people don't have the necessary skills to use telehealth or have access to the technology that is necessary so that they can benefit from telehealth. So it's important to ensure that the telehealth is available to those who need it. And it's also important that people are educated about telehealth and aren't restricted from using it because they don't have the necessary technologies or language barriers. So it's a really key tool for responding and continuing to respond to COVID. So that was a few of the takeaways from our discussion. In New York specifically, I believe I'm going to pass it over to Deborah Darcy of the American Kidney Fund, and she's going to talk a little bit about her discussion with folks from the state of Texas.
Thank you, Nick. So good morning, everyone. And as Nick said, my name is Deborah Darcy, and I am the Senior Director of Government Relations at the American Kidney Fund. Before I start, I want to second what my colleagues have said about those individuals with compromised immune systems being particularly vulnerable. Access to information, access to healthcare providers, and access to the antivirals can be the difference between life and death for them. So I had the honor of moderating the Texas listening session, and Texas is a big state, so we had a wide range of experiences. We heard from a social worker from Houston and a public health policy analyst, a physician who cares for HIV/AIDS patients, the director of a small local health department in a rural area of West Texas that is in a community of about 20,000 people. We listened from them and other participants, and I want to thank them now for sharing their experiences. So to get a full understanding of requests for and access to the antivirals for those who are immunocompromised and for those who do come down with COVID-19, we asked a number of questions similar to New York, like how can the health departments in Texas help individuals who are at higher risk for complications and death due to COVID become more knowledgeable about their risk status. We asked about hesitancy of people who are immunocompromised about the antivirals, and that what barriers are there in the state. So I'm now glad to provide some details and highlights from our discussion and provide some insight on what is happening on the ground in Texas. So the discussion did start with the acknowledgement that the denial of COVID-19 as a public health problem has been a barrier in Texas. Some people with immunocompromised conditions don't know that they are at high risk due to some of the political rhetoric. However, participants in the listening session reported that the city of Houston made resources available and education available so people would understand their risk. Also, it was reported that in the more rural areas, that people with compromised immune systems really depend on their doctors and their public health clinics for information and advice on what to do. Hence, the public health clinics and the individual healthcare providers, like the doctors and the nurses and the nurse practitioners, really served as educators on the pandemic and discussed steps that individuals should take to protect themselves and what they should take if they get COVID-19. Another barrier was the lack of proactive information on test to treat. And Nick just mentioned it, and it's a federal program that provides COVID treatment for the uninsured, for those on Medicaid, for those on Medicare. And a lot of patients didn't even know that the program existed. And when a patient did come down with COVID, there were reports of patient hesitancy. So people with compromised immune systems who are at high risk of being hospitalized and have higher risk of mortality, they really needed to take the antivirals because it reduces the chance of hospitalization and becoming very ill and reduces their chance of death. We heard that there were concerns from patients and that in these cases, the doctor's role was very important. They had concerns of interaction between the antivirals and the drugs that they are, and the current drugs that they're taking. But depending on the window, on their high risk status, in some cases, you can stop taking your current medication to take the antivirals to make sure that you don't come to COVID-19. So in these cases, it is really important to have access to your doctor, which once again, telehealth is so important, and also funding the public health clinics, which did provide such a role in educating and being a resource that people could trust. Another barrier to care was that the antivirals were not available at all the pharmacies, but they were available at the specialty clinics. So ensuring there is access to antivirals at the pharmacies could be a way of getting the message out that COVID, unfortunately, is still here and it's still causing people to become very sick and it's still causing death. There were high praise for rural county COVID-19 management in Texas. The local health clinics have provided leadership for those who are at high risk, and they are participants in the test and treat program. So they have been able to provide antivirals to those who are extra vulnerable to COVID-19 and to provide the antivirals at no cost because they do participate in the test to treat program. Also, their doctors have provided continuity of care. So the patients know the doctors, they are diagnosed by the same doctors and have follow-up. But those who don't currently go to these clinics in these rural areas need additional information and assistance. And we discussed low copays. So low-income people, sometimes they can't afford even a $2 or $5 copay. So if we want to ensure that people with compromised immune systems have access to antivirals, the copays need to be very low or to be provided with outpatient cost sharing. And this is important in the private insurance companies that these are provided at the low cost or zero cost sharing. So the federal policies that we'll hear from next on funding for public health infrastructure, on telehealth, on information, on getting the information out to those who are vulnerable. These will really help patients, and just thank you for your time.
Thank you, Deborah and Nick, for joining us today and outlining these robust discussions. Based off the discussions, there were three major findings. There we go. And these include: one, access to antivirals, maintain policies to ensure Medicare and Medicaid patients have quick access to free COVID-19 treatments, and call on private health plan sponsors to maintain low copays for these vital treatments. Two, funding for public health. Support the Centers for Disease Control and Prevention funding for public health initiatives at the state and local level to support community outreach and education related to COVID-19 prevention and treatment. And finally, telehealth. We urge Congress to come together to pass telehealth permanency legislation well before the end of 2024 and to encourage licensure compacts that facilitate provider practice across state lines. We look forward to working with you on these policy recommendations in 2024 and beyond. Last but not least, I'd like to welcome Alexis Apple, Director of Federal Affairs for the American Telemedicine Association, to provide an update on telehealth legislation pending in Congress. Alexis?
Wonderful. Thank you so much. And hello, everyone. It's great to be with you today. Thank you, Lynn and Jory, for inviting the ATA to speak on these critical topics, as we've just been hearing about. It's really been inspiring to hear all these different stories from patients and just the real life use cases on how telehealth is really being deployed and utilized and the benefits that it provides. So excited to talk about the policies that are hopefully going to be made permanent or extended at the end of this calendar year. But as Lynn said, my name is Alexis Apple. I'm the Director of Federal Affairs at the ATA, which was founded in 1993, over 30 years ago. Can you imagine that? And it is a nonprofit organization. We have over 450 members that really range the gamut of the healthcare industry. So we have hospital system providers, academic centers, asynchronous companies, telehealth only providers, really anyone you can think of is part of the ATA membership, which is really exciting. And then I'm also the Senior Manager of Federal Government Affairs at ATA Action, which is our advocacy arm. Next slide. One more slide. Thank you. So yes, this is one of the biggest years for Medicare telehealth policy yet. I think we all know this. All eyes are going to be on Congress as soon as these appropriation and funding bills are dealt with. All eyes are going to be on telehealth, that's for sure. And we are deeming this the telehealth Super Bowl. So for football fans out there, this should be a good term that you can hopefully utilize in the future. But this is when all of the Medicare telehealth flexibilities are set to expire the evening of December 31st, 2024. All the gains we have made that increased access to care for millions of patients will be lost if Congress does not act before, again, December 31st, 2024. So what items are set to expire at the end of this year? So I broke this chart up on the screen. I broke this into two categories. One's legislative. So the legislative issues that Congress can address, right, without any agency authority, and then regulatory, which is all basically what CMS can address without Congress's authority. So let's start on the legislative side of things. So first is your basic, of course, Medicare teleflexibility. So what all does that include? That includes your geographic and originating site waivers. So that has allowed all of the patients to receive care when they need it across the United States. So whether you were in your home, in your car, or whether you were in an urban area or a rural area, you could receive reimbursable telehealth. Second is to maintain audio-only coverage. For those of you who live in rural or underserved communities, you understand how important this is. It's not necessary for every visit, right? But in certain circumstances, audio-only is needed. So we don't want to see that coverage be pulled out from under us. Another one is maintaining the expanded list of eligible Medicare providers that can provide telehealth services. So this list was expanded to physical therapists, occupational therapists, speech language pathologists, and audiologists during the pandemic. We'd love to see those providers to be able to be maintained and allow them to provide telehealth services moving forward after calendar year 2024. The ATA is provider neutral, meaning we truly believe any provider should have the option to provide telehealth when it's clinically appropriate and it meets the standard of care. Obviously, that's a decision that they need to make in lieu of their patient, with their patient. But we really just believe that in statute, we shouldn't be naming the types of providers that are necessary to provide telehealth. It really should be any provider and leaving it up to their discretion. Another Medicare flexibility is allowing rural health clinics and federally qualified health centers to provide telehealth services and be reimbursed for them. And then another one is, of course, waiving the 6-month telemental health in-person requirement. So in 2020, telemental health became a permanent part of the Medicare program, which is great. So it no longer has the geographic and originating site waivers. You're allowed to do it audio only, all these other things. But they said, hey, before you can have any type of telehealth visit, you have to see your provider in person at least 6 months in advance. Well, in-person requirements are big barriers to care, right? It kind of defeats the whole purpose of telehealth. And we just believe that these are inappropriate guardrails. These are not the way to move forward. If you're trying to maintain program integrity and you're trying to avoid fraud, waste, and abuse, in-person requirements are not the way to go. There's other guardrails that we put into place that are less substantial. And that would, still allow that access to care that's needed. So that's something that we're trying to permanently waive as well. Another big one is, and we're going to move on to the commercial side of things now, is the first dollar coverage of telehealth and high deductible health plans, health savings accounts. So for those who participate in high deductible health plans, it essentially during the pandemic allowed them to receive telehealth coverage pre-deductible. So we'd love to see that be maintained. We found that to be very successful. And then telehealth is an accepted benefit. So this is one of the only telehealth provisions that actually has already expired. It expired in this calendar, or the end of calendar year 2023. And it essentially just allowed part-time contracted workers to receive telehealth coverage who maybe otherwise wouldn't qualify for full healthcare coverage. So it allowed them to have a little bit of access to care. And they were still eligible to be in the healthcare market and find which insurance was best for them. But it essentially allowed the employer to provide this telehealth coverage, even though they couldn't offer the full healthcare coverage. So we're working with Congress to hopefully get that addressed sooner rather than later, just because that already expired. And then lastly, on the legislative side is your acute hospital care home program, which basically allowed patients with acute symptoms to, instead of being hospitalized during the pandemic, they were able to receive care within their home and be treated within their home. Doctors, nurses would come in, do different testing, and just receive treatment from their home. And it has been very successful. It's lowered costs, lower readmission rates, better patient outcomes. So we'd love to see that program be maintained permanently. So that's all on the legislative side of things. That's all what Congress can do and has to address before the end of calendar year 2024. I'm going to move over to the regulatory side of things, which is everything that CMS can do without Congress's authority, everything that's in their jurisdiction. So the first one, and this is not under actual CMS's jurisdiction, this is under the Drug Enforcement Agency's jurisdiction. And this is permanently extending the in-person waiver for the remote prescription of controlled substances. So let's go back a little bit. So there was something called the Ryan-Haight Act, which was enacted in 2008. And essentially was a 18-year-old boy named Ryan Haight who overdosed on a stimulant. And he got it from a rogue website. It was not actual telehealth. He never talked to a doctor via video visit. He just went online and got a prescription and basically overdosed. So the Ryan-Haight Act was implemented in his honor, and it essentially required an in-person visit before any type of provider could prescribe a controlled substance. Well, fast forward to the pandemic, of course, we couldn't have that in-person requirement. So they waived that. We've actually seen a lot of great outcomes come about that, especially in the telemental health space, behavioral health space. And so we are working hard to try to permanently waive that in-person requirement. And one way that the DEA can do that is through a special registration process, which basically was what the Ryan-Haight Act had said. Like the DEA could come out with this special registration process for providers, and it could essentially waive this in-person requirement, but they would have to meet other types of requirements in lieu of that. And so we're expecting the DEA to come out with some sort of proposed rule early this year outlining what that process would look like. And then we all as an industry will have the opportunity to comment on it. And then they will implement hopefully a final rule before the end of calendar year 2024, which is when this in-person requirement waiver is set to expire. Moving on to what CMS now has jurisdiction over, we are deeming this the Box 32 issue, which is basically the provider address flexibility. So during the pandemic, on the Box 32 form, your Medicare enrollment form, a provider did not have to list their home address. They could list their practice address that they were associated with. And this obviously helps maintain provider security and help reduce administrative barriers and burdens for a lot of hospital systems, so they didn't have to keep updating every time a provider is practicing from home or traveling. They didn't have to update that address. And so this is a big concern for a lot of ATA members. This is actually the #1 besides the Medicare teleflexibility. So it's something that we're closely keeping an eye on and working with CMS to address before calendar year 2024 is over. Virtual direct supervision, so allowing a provider to virtually supervise their assistants while they're doing a surgery or whatever the case may be. We want to see that be maintained permanently as well. And then you'll see just some of the other regulatory things up here, maintaining the telehealth codes. There was over, I think, 160 telehealth codes that were on a temporary basis that were covered temporarily during the pandemic, and we'd love to see those be maintained permanently. And yeah, we'll keep it at that for now, just because I have so much else to talk about. But let's move on to the next slide. So the biggest thing I want to discuss here, so this is our legislative playbook, keeping in theme with the Super Bowl. So I want you guys to take a look at the most right column on the screen, which is the permanent legislation that's been introduced in Congress this far. So we have 2 comprehensive telehealth bills that have been introduced. One is the Connect for Health Act, which would make permanent all of the Medicare teleflexibilities. And then you also have your Telehealth Modernization Act, which was just introduced yesterday. So I need to update this slide. But those are two great bills that hopefully you all could support. And if you ever go to the Hill, talk to your member of Congress about, because it would ensure that you guys get continued access to this critical care, critical access to telehealth services moving forward post calendar year 2024. And the way I look at these bills as they're most likely not going to pass standalone, right? They're most likely going to pass in some sort of like larger package, healthcare package. We've been hearing and we've been having lots of meetings with different stakeholders and members of the House and the Senate, and they have said that this most likely is going to occur in the lame duck session. So after the election, they've just had so many setbacks with funding. It's just pushing things farther and farther. But the ACA is going to continue to push, like Lynn and this group, going to continue to push act sooner rather than later, because the healthcare system does not act on a dime, and we know that. And both the bills are bipartisan, highly supported. So we're hoping that something like this will get through and stuck into some sort of large omnibus at the end of this calendar year. And then we also have other bills for the other issues that I outlined on the legislative side of things that would make those provisions permanent, specifically the commercial provisions, and then the TREATS Act, which relates to the Ryan-Haight Act, as I discussed, and removing that in-person requirement, but specifically only for controlled substances that treat opioid use disorder and substance use disorder. On to the next slide, please. So as I kind of noted in the last slide, what are some moving vehicles that could lead to this touchdown, right? That could lead to permanency or another long extension. And as I said, many of the bills that I mentioned on the last screen, it's great that they've been introduced, that they have bipartisan support, but they most likely are not going to pass on a standalone basis. It's going to be in some sort of large healthcare package that's coming down the pike this year, which there's really nothing in sight as of now besides some sort of omnibus at the end of this year, which is fine, but we're going to continue to push from now rather than later. Just because everyone needs that certainty in the long run. But we do believe Congress is going to act this year. We've had conversations with actually all of House and Senate leadership, all key committees of jurisdiction, and everyone is supportive of telehealth. They are going to act on it this year. It's just how and when are they going to do it. Next slide. And this, I actually kind of already just described this in the first slide, but this is the action that the Drug Enforcement Administration has taken during the pandemic to basically waive that in-person requirement for the prescribing of controlled substances. And just moving forward, you know, what we could see from the DA, as I said, is they could release this proposed rule outlining a special registration process, or if they feel like, hey, we still don't have enough information yet, we want to gather even more information from stakeholders, we can extend the flexibilities through calendar year 2024. Yet again, they can just keep extending. Next slide. And then last but not least, this is our regulatory playbook. So I went over the legislative playbook. Now we have a regulatory playbook. So the biggest items I want to address here is how can all of these regulatory flexibilities get addressed before the end of calendar year 2024? And for those of you who are not familiar with the process, there's something called the physician fee schedule, which is like an annual process that determines all of the Medicare payment rates for providers and the services that are deemed appropriate for Medicare providers. And so normally the proposed rules released in July, in the summertime, right around 4th of July. So it's always a great time. We vet through the PFS, and then it gives opportunities for stakeholders like ourselves to comment on key issues, which we're going to be commenting on all the telehealth issues that we outlined. And then they will release a final rule normally in like November, sometimes December. So that's usually how it works. It's an annual process. It's a great process, really, because we know that they have to address these things, and this is the way they're going to do it. But I think the biggest thing I want to stress here is if we don't have, and we've seen this during the pandemic, there's going to be legislative flexibilities and regulatory flexibilities that are probably not on the same timeline, right? Because Congress is not going to act most likely before this draft rule is published. So you might have some flexibilities that are running on different timelines. It can be very confusing for providers, for healthcare systems. You might even see some payers start to pull back on telehealth coverage, which we've seen previously because there's so much uncertainty. So we just urge CMS and Congress to really work together this year to figure out, are you going to do an extension? Are you going to make things permanent? And what exactly do those flexibilities look like, and make it well known to the public, to all of us, so we're all well aware before December 31st, 2024, what to expect and what we can implement moving forward. And I think that's all I had. Next slide. I think I did a good job. I felt like I had a lot to go
Great.
Awesome. Thank you.
Well, thank you, Alexis, and thank you everybody for coming. I just wanted to, before we wrap up, I wanted to let people know that we will be doing a follow-up where we have a great informational fact sheet that we'll be sending links to that is connected to our website, as well as any answers to questions that were posed that need to be addressed. But I really want to thank everybody for joining us today. This has been very informative. And again, if next slide, actually, if you have questions, you can email me at llbizo@primaryimmune.org. And if you can't remember that, just you can reach out to the Immune Deficiency Foundation and they know where to find me. But please, feel free to reach out. Like I said, we're going to do follow-up, and I really want to thank everybody that presented today and appreciate all of you taking the time to listen to this important information. And remember that immunocompromised people are still at risk, and we need to make sure we have protections in place to make sure we respond to our concerns of this community. So thank you, and we'll for joining us, and like I said, we'll be doing some follow-up.